Good afternoon. I'm Bob Smith. I'm going to talk with you about HIMSS and cancer screening. So the HIMSS data set it's been published annually. Its intention is to guide employers in making choices about plans by being able to compare them on their delivery of important chronic disease management services or cancer screening. And over the years, in particular, there has been a strong interest in the degree to which getting a HIMSS measure can, in fact, be a catalyst to increase cancer screening rates. The assumption is, of course, if you have to measure it, you're going to be paying attention to how well you do at that particular task. Right now, there are 3 measures of cancer screening in HIMSS: breast cancer screening, cervical cancer screening, and colorectal cancer screening. These measures follow the Preventive Services Task Force recommendations. And as the task force recommendations evolve, so do these HIMSS measures. And I'll give you a good example of that. Cytology screening is increasingly viewed as, in fact, has been shown to be less effective than HPV testing. At the same time, we are not entirely certain that all women in this country have access to HPV testing. So right now, there are options for cervical cancer screening that include cytology every 3 years for women ages 21 to 64, or HPV-based testing, which would include co-testing, an HPV test and a cytology test for women ages 30 to 64. But also a primary HPV test, and in other words, an HPV test alone every 5 years, which is the preferred test from the American Cancer Society, and one also prioritized by the Preventive Services Task Force. Co-testing and primary HPV testing have roughly the same sensitivity, but primary HPV testing is much more efficient because you are only doing one test and you are going to send fewer women to colposcopy. HIMSS measures for breast cancer screening, as you would expect, follow the task force, which means it would be a mammogram every 2 years for women ages 50 to 74. But note that in this particular measurement guide that there is a 3-month grace period built in, which is a nice degree of flexibility because none of us get the tests that are recommended on time. And it gives some flexibility to plans to be able to accommodate those people who are a couple months late in the measure and include them in the measure. For colorectal cancer screening, there's also this degree of flexibility, as you can see where I have these arrows, that flexible sigmoidoscopy and colonoscopy can be included in the measure if, in fact, the test has been taken, has been undertaken, within 4 years prior to the measurement year for flexible sigmoidoscopy and 9 years prior to the measurement year for colonoscopy. Note also that a common, still unfortunately too prevalent way of performing colorectal cancer screening is when you do a single sample stool test after a digital rectal exam in the office, is specifically called out as not qualifying for the patient having had colorectal cancer screening. This is the kind of testing we've been trying to discourage for many years because its accuracy is so low. Now, I'm going to focus mostly on colorectal cancer screening, and these are the colorectal cancer screening rates from the various plan types from 2008 to 2018. And you can see that there's 2 different kinds of commercial plans, commercial HMO and commercial PPO, and there also are 2 Medicare plans. There's Medicare HMO and Medicare PPO. The trends for these 2 types of plans are combined and shown in the graph on the right. And as you can see, in 2012, the performance of these 4 plans, which have been roughly similar then, diverged rather dramatically. And this was because that was when the CMS established the STARS program, which provided additional incentives to achieve high rates of screening, in particular financial incentives that would work to the advantage of a plan if, in fact, it got its rates up to the levels that measured 4 stars, for example, or 5 stars. The HIMSS measures alone did not have that impact on the commercial plans. Now, back to this issue of, well, does a HIMSS measure, if you get a HIMSS measure, is it going to contribute to increasing screening rates? And I think the example of colorectal cancer in the study that was done in Pennsylvania is a very good one. So around 1999 and 2000, there was a nationwide survey that looked at how colorectal cancer screening was covered. Only slightly half of the plans covered colonoscopy. Fewer than half had any system for monitoring delivery or outcome of screening. Fewer than 25% had patient reminder systems, and only 16% of the providers associated with these plans had reminder systems, and even fewer had tracking systems to monitor whether adults had actually undergone screening, and even fewer had tracking systems to monitor whether an adult who had a positive screening test had been followed up for that test. Now, in 2003, also largely as a result of petitioning by the member organizations in the National Colorectal Cancer Roundtable, NCQA decided to establish a HIMSS measure for colorectal cancer screening, and which they intended to launch in 2006. Developing a measure usually is a several-year process, and the plans are notified that, in fact, that a measure is coming, and it gives them an opportunity to begin to anticipate how they are going to achieve measurement of those screening rates. What this did was, to colleagues in Pennsylvania, create a nice opportunity for a natural experiment comparing the data from the previous national surveys to plans performance after 2006 in the state of Pennsylvania. So they surveyed all the plans that met certain inclusion criteria in Pennsylvania. They needed to cover at least 25,000 members and have at least one commercial plan in the state. And in the end, there were 13 plans representing about 8 million people that met this inclusion criteria, and all responded to the survey. And the survey also included questions about the degree to which the HIMSS measures actually had influenced their current policies towards colorectal cancer screening. So the table shows pretty simply that before 2003 compared to 2003 and after, there was a change in the guidelines, basically that the tests that plans would cover. They began measuring colorectal cancer screening rates, and they had a sizable percentage had implemented the HIMSS measures. In addition, what we saw was they covered more kinds of colorectal cancer screening tests, and in particular, they had established new or updated enrollee or provider reminder systems and tracking systems for adults who had been tested with a positive test. So the takeaway points from these investigators were that the plans did revise their screening guidelines to shape physician recommendations for screening, that many of them implemented guidelines that did not previously have them. They began measuring screening rates, and they established reminder systems and tracking systems for patients. These are all changes that would be viewed as very positive for those that were looking for additional incentives to motivate plans to become active participants in promoting recommendations for screening from the Preventive Services Task Force or the American Cancer Society, and in particular to use benefits that were included in the plans that they might otherwise not been using. So in summary, and given the limited amount of time, I was not able to show you the other data, but there are studies that have shown that HIMSS was influential in raising breast cancer screening rates and shaping how evolution in cervical cancer screening rates were taking place. The influence of HIMSS is enduring, but it's greatest during the period when the uptake of a preventive health intervention is low. As you saw, metrics tied to more direct incentives, and in particular revenue, such as the Medicare STARS program, create additional incentives that seem to push performance beyond what is, you might say, are the average levels of screening that we see in the population, that really at that point don't really allow the employer to distinguish much between one plan or another. One good bit of news is this past year, NCQA agreed to work with National Lung Cancer Roundtable member organizations to explore developing a HEDIS measure for lung cancer screening. That's going to also stimulate, I think, a lot of work to recommend best practices in identifying adults who are going to be eligible for lung cancer screening. If the task force draft recommendations are accepted, and we have every reason to believe that they will, it's going to broaden the number of adults who will be eligible for screening, which I believe will exert additional pressure on plans and health systems to identify these people and get them in for screening. And ultimately, we should see the contribution that HEDIS has shown with screening tests in the past to contribute to an acceleration of the uptake of lung cancer screening beyond what we've seen right now. Thank you very much.